Today, can we start? Tech team, can we start?
Yes, sir.
Okay.
So we are starting in 3, 2, 1. Please start.
Okay. Good evening, Arpita ma'am. Good evening,
Good evening.
doctors. So it's a great privilege for us to have Dr. Arpita Roy with us for the talk Reaching New Heights in MHSPC Care. Dr. Arpita Roy is a assistant professor in medical oncology, State Cancer Institute, Guwahati. So, madam, it will be kind of you if you can start your talk with this. So, slides shared by you. So, madam, your video, if you can give your video also, then for some time.
Okay.
Okay, ma'am.
Is it working? Hello, am I audible?
Yes, ma'am, you are quietly audible.
Okay. So yeah, good evening. We today will be discussing about reaching new heights in metastatic hormone-sensitive prostate cancer care. Actually, we've come a long way over the years. We've come a long way since ADT was used alone in prostate cancer, and now we have also come to the use of triple drug in upfront itself in prostate cancer. So when we look at prostate cancer as a whole, we see that we have a lot of patients who come to us in a locally advanced stage, and a lot of them initially have a biochemical progression. Some of them progress very soon to develop either metastatic hormone sensitive prostate cancer, or if alone on EDT, they may also develop CRPC. So, what is important is that we catch hold of these patients initially itself so that we can delay the progression to develop CRPC, because once that develops, it is very difficult to control the disease of these patients, and they very soon go into terminal disease and die. Yeah, please take the next slide.
Madam, you can switch off your camera now.
Okay. Yeah, so as I was saying, that we started initially with the Stampede trial. Before that, ADT was used just alone as a treatment option for prostate cancer, even in the metastatic setting, because a lot of these medications were not available at that time. A very major trial which came into play was the Stampede trial. Now, this was a multi-arm trial, a multi-platform trial, which essentially had seen a lot of things together. The use of docetaxel as a chemotherapy drug, the use of abiraterone, the use of radiation in low volume disease, as well as the use of certain other agents such as zoledronic acid, which, however, was not proved to be very beneficial. And the Stampede trial showed that when docetaxel was used, especially in high disease burden patients, it did improve the overall survival of these patients, and so was the use of abiraterone. And then it actually paved the way for use of abiraterone as a standard of care in these metastatic hormone-sensitive patients, along with ADT upfront itself. And they found that use of radiation in low volume disease was also found to be beneficial. It was not so much in high volume metastatic disease. Next slide, please. Yeah, as I was saying, so for the low volume disease where it was less than 4 bone mets, the use of local radiation to the bony sites was proven to be beneficial in the metastatic hormone sensitive patients in the arm where radiation was used in the Stampede arm, along with the standard of care, which was only ADT at that time. Next slide, please. Over the years, we see that a lot of other androgen receptor, the pathway inhibitor drugs have come into play, which mostly there were a few trials which have paved the way for the now standard of care, which is triple drug in case of high volume disease. The most important of which was the Charter trial. Now, the Charter trial had divided it into a high volume disease as a low and a low volume disease based upon the presence of visceral mets, the presence of more than 4 bony sites, and which also included sites which was apart from the axial skeleton. And this showed that the use of docetaxel upfront along with ADT in the high volume disease had an overall survival benefit, and this thus became the standard of care now. And then the STAMPEDE trial had established the use of docetaxel and abiraterone also. In the CHARTED trial, they found that in the high volume disease, there was an improvement in overall survival of almost 16.8 months with a significant p-value and a hazard ratio of 0.63. Whereas in low volume disease, there was not so much improvement in the overall survival and the p-value was not very significant. After this chartered trial, there were other trials which started establishing the use of the drugs such as the enzamet trial and the use of apalutamide in the Titan trial. So the Latitude trial had used abiraterone, and this Latitude trial had actually divided the groups into high-risk disease and low-risk disease. And when we talk about the overall survival, the benefit was found to be in the high-risk disease as well as low-risk disease for the abiraterone in the Latitude trial. Next slide, please. Yeah, we discussed this. The next slide, please. Yes, I was mentioning in the Latitude trial, the use of abiraterone in the high-risk patients did show a lot of benefit. And this high-risk group was based upon the Gleason score of more than 8, the presence of more than 4 bony mets. Yeah. Next slide, please. Yes, so along with the use of abiraterone, which we face normally in clinic, is that we have to give prednisolone, as we all know. But there are a few side effects which occur even in patients who are receiving prednisolone. So the use of prednisolone becomes a little challenging in these patients, especially in patients who are diabetic and patients who have side effects of prednisolone, of osteoporosis, etc. So the use of the prednisolone along with abiraterone is challenging, but mostly it is a very well tolerated drug, and the patients usually do not have much of side effects. Some amount of LFT derangement with enzymes increasing does occur, but that is usually easy to negotiate with and usually gets better with some supportive treatment and off treatment. Next slide, please. So Titan trial had also looked for apalutamide in this same setting, where instead of the use of abiraterone, along with ADT, which is always the backbone and always has to be present, unless the patient has undergone a bilateral orchidectomy, the medical suppression needs to be given. So when apalutamide was given also for them, there was an overall survival, and this was more beneficial in the low volume disease in this setting compared to the high volume disease. Next setting, please. Similarly, enzalutamide was also used in the enzamet trial, and this also showed a good overall survival, especially in patients who had a low volume disease. Even in high volume disease, there was a numerical benefit. However, the p-value was not very significant. Next slide, please. So basically, all of these were the dual therapy agents which were used in upfront metastatic hormone-sensitive prostate cancer. However, there were 2 major trials which had looked at whether we can actually use a triplet therapy in the first-line setting itself. And I would say that the trial which paved the way for triplet therapy was the PEACE-1 trial. Initially, which had used ADT as a backbone along with docetaxel and abiraterone. It was more of a proof of concept trial at that time, where abiraterone was being used in the setting along with docetaxel and ADT, and this was more so in the group which was the high volume disease, as was already placed by the charter trial. Next slide, please. So this was a phase 1 trial. It was a 1:1 trial where the patients had received the standard of care, which was ADT plus minus docetaxel along with abiraterone. And these were patients who were either de novo metastatic or recurrent metastatic, and prior chemotherapy was not given to these patients. So in this trial also, they found that there was an overall survival benefit in the patients who had received the triple drug regimen, especially in the patients who had a high volume of disease. Next slide, please. Yes, so in patients who had a high volume of disease, the separation of the curve was maintained, and the overall survival was higher compared to the low volume disease. Next slide, please. So now this actually paved the way for the Arisons trial. Now the Arisons trial was also a triple drug trial, and in this trial, all the patients had received ADT along with docetaxel instead of some patients who were not given docetaxel in the phase 1 trial. So this was basically, if I say that this was a more confirmatory trial for the phase 1 trial. The phase 1 was more of an abiraterone-based triplet drug trial. And this was confirmed with the phase 1 trial that in a population which is a high-risk population, when we are giving a triple drug therapy along with ADT and docetaxel, when we add darolutamide instead of a placebo, there was a definite overall survival benefit. And this was a very simple 1:1 clean trial, which showed that in patients where the standard of care, which is ADT with docetaxel in high volume disease, was either given darolutamide or placebo, then there was an overall survival benefit in the investigative arm, which is around with a hazard ratio of 0.68, which showed that there was a 32.5% reduction in the death. Next slide, please. And they were looking at overall survival as a primary endpoint. However, there were several secondary endpoints also. So when we looked at the overall population, there was a hazard ratio of 0.68, as I was saying. So that is a 32.5% reduction in the death. And this was maintained in both the high risk as well as the low risk patients. Next slide, please. And there were several secondary endpoints also, which were improved, such as the time to development of CRPC, the time to pain progression, the time to the next use of antineoplastic agent, and also the time to skeletal events. And when we actually compare both the trials, abiraterone and darolutamide trial, that is a phase 1 and the Arisons trial, although the head-to-head comparison is not possible, but we see that docetaxel was initially not used in the phase 1 trial, but in the Arisons trial, docetaxel was given to all patients. And so it was basically paving the way for the use of triple drug therapy in this trial. And we see that in the Arisons trial, the development of CRPC, the time to progression to CRPC was delayed. The pain progression time was also delayed, and the time to first use of antineoplastic agent, the second new antineoplastic agent, was also delayed, and the occurrence of skeletal events, which was either bone involvement or the use of some orthopedic intervention, was also delayed. Next slide, please. One important concept that the Arisons trial had looked into was the PSA progression and the PSA response. So they had seen the PSA response as PSA 50, PSA 90. So 50 being less than 50%, more than 50% reduction in PSA at a particular time, and more than 90% was PSA 90. So they found that throughout the period, when they checked at 12 weeks and 24 weeks, throughout the period, the response to PSA was maintained, and the progression of the PSA was delayed. And also the occurrence of undetectable PSA was much more with the use of the triple drug therapy when darolutamide was used. Yes. Next slide, please. Yeah, so this is the same thing, that it had achieved a longer period of no disease progression with an improvement in the overall survival, which was maintained throughout all the groups. Next slide, please. Yeah, even in the lower volume disease, there was delay in the PSA progression, and the undetectable PSA levels were maintained for a longer period of time. So one more important factor that came into play was about the side effect, and it was believed that when there was triple drug use, then the side effect, the toxicity level would have been much more. But they found that the toxicity level was actually not much more, and the toxicity was mostly the neutropenia for the docetaxel arm mostly. But one advantage that darolutamide had over the other RPs were that there was a lesser CNS penetration. So compared to enzalutamide, which we know that there is a lower, the seizure risk is high in enzalutamide, the risk of cognitive decline or seizure was actually less with darolutamide. So for patients in this day and era, when we consider a high volume disease, now it is important and pertinent that if patients are fit with a good performance status with a high volume disease, we should hit hard and hit early with the triple drug regimen, if feasible, if possible, because the more we can delay the occurrence of CRPC, the more will we delay the progression of disease and thereby death. So so there's also an important concept of sequencing in prostate cancer, and we know that because switching over from one RP to the other also becomes difficult, and then after a patient has progressed on one RP, it is very difficult to either give chemotherapy or finding a targeted therapy becomes difficult at that stage. So it is important that we hit the patient hard at the very first go itself. But yes, it is also important that we tell our patients about all the options available. Okay, thank you so much.
Thank you very much, madam. It was a nice presentation from your end, and looking forward to you for such good presentation in near future. So with this, is there any question in the floor? Can you please give it in a chat? I think there is no question. With this, can we move to Smita Kumari, ma'am? Madam, it is your choice. You want to stay here, or you have some other work, so it is your choice now,
It's
ma'am.
okay, it's okay. No problem.
Okay.
Yeah.
Ma'am, if you can. So prior to that, let me introduce. Hello. Yes. Tech team. Does it require to give another countdown?
No need, sir.
Okay. With this, good evening once again to all. Now, Let me introduce Smita Kumari ma'am. Smita Kumari ma'am is a consultant medical oncologist in Health City Hospital, Guwahati. So with this, I would like to request Smita Kumari ma'am to present her presentation. It's all to you, ma'am.
Just a sec. I'm just coming. Is my screen visible?
Madam, your screen is visible.
Okay, thank you. Good evening, everyone. I'm Dr. Smita, and today I have got an opportunity to talk about on advancing metastatic hormone-sensitive prostate cancer treatment, darolutamide without chemotherapy, that is, an ARANOTE evidence. Now, we are generally, we have seen the evolution that second generation ARI, darolutamide, is approved for the treatment of non-metastatic castration-resistant prostate cancer and hormone-sensitive prostate cancer in combination with the docetaxel. Darolutamide is indicated for the treatment of patients with metastatic hormone-sensitive prostate cancer. Now, as already discussed by Dr. Arpita, that the evolution that she has already spoken about the chartered stampedes in all Titan's speech trials and Harrison trials. Now, I'll be more focusing, despite the treatment with ARPI, the AGT plus docetaxel. Oh, just a sec. Moving. Despite of treatment with ARPI plus ADT or the docetaxel plus ADT, a large proportion of patients with hormone-sensitive prostate cancer will progress to metastatic castration-resistant prostate cancer, as we generally see within 3 years of survival, within the 3 years of diagnosis. Now, there was an unmet need for the patients to just have an efficacious treatment without any significant toxicity. The Aracin trials has already seen with the combination with docetaxel and darolutamide. Then we just came up with darolutamide in combination with ADT would provide a efficacy benefit with a favorable safety profile in hormone sensitive prostate cancers and was demonstrated well in the Arano trial and was significant in the Indian patients. With Arano data, the darolutamide has a potential to change the treatment paradigms, as now it is the only ARI that would be used with or without chemotherapy. Now, already discussed about the Aracin trials that we have used darolutamide plus ADT plus docetaxel. Now, and we have seen its efficacy as a triplet regime versus the doublet therapy. Now, coming up to the Arano trial, that is the evaluate darolutamide plus ADT versus the ADT to provide a new treatment option for the hormone sensitive prostate cancer without docetaxel. Now, there was a double-blinded randomization was done. In the one arm, the patient was taken and given with darolutamide plus ADT, and the other arm was received a placebo plus ADT. The the primary endpoint was obviously a progression-free survival, and we have also taken into the account of overall survival plus the time of castration-resistant prostate cancer. That is very important, and the PSA time of PSA progressions. Also, the rate of undetectable PSA, the time of pain progression, and the safety profile. Now, we have the median follow-up of the patients with darolutamide was around 25.3 versus the placebo group was 25 months. Now, the demographic that have been taken, the more of the Asian population, whites were obviously 251, and the Asians were 141 patients in darolutamide arm versus the placebo arm. And we have also seen that the patient where there was a metastatic settings more with the darolutamide arm versus the placebo arm, and also the disease volume was also considered that was high in darolutamide arm. Now coming to the trial one vision trial and the Aranaut trial, that was demographically represented an embark trial. The Now coming to APAC regional representation, that was China 65 and India was 61. Coming next to the Taiwan and this. Now coming to the benefit of darolutamide plus ADT on a progression-free survival was consistent with the subgroup, and including the patient was with the high and the low volume disease both. The endpoint, that was overall survival, was good with the darolutamide arm, and also the time of progression to castration resistant was also taken into the account, and the time of that at the time of primary analysis OS data was are immature. So since OS is immature, the patient would not be followed for the survival, and all remaining as per protocol, the placebo patients offered crossover with the darolutamide after primary analysis. Now coming to the time delay in castration resistant prostate cancer and the time of pain progression, we can see that the time was taken was prolonged in the darolutamide arm versus the placebo arm, and the same was seen, not much difference, but still it is significant. There was delay in the pain progression, can be a high importance in the patients, and have not been demonstrated in ARIs. Now coming to the darolutamide plus ADT achieved deep and durable PSA response. The PSA at any time or during the treatment was less than 0.2, and the time of PSA progression was also very significant. The 63% of the patient in the darolutamide doublet arm attained a PSA of less than 2. This represents that 69% of improvement in the time to PSA progression in the darolutamide arm versus the ADT alone. Now, this is also the proportion of patients that received an undetectable PSA with the darolutamide versus the placebo in both high and low volume subgroups. This is like this was the same figure like already discussed by Dr. Arpita. Now coming to the subsequent life prolonging anti-cancer therapy. The patient with subsequent life prolonging anti-neoplastic therapy that received in was in 66% of the 66 patients when 203 patients was taken into account, and with the placebo it was 68 when 160 patients was taken into account, and docetaxel was into 46, and it was also 46 but in the subgroup of 160 only. Now the incidence of T's were similar between the treatment groups, and discontinuation were lower in the darolutamide trial. We see that when we go for any side effect, it was overall grade 3 and grade 5 was very almost 405 patients was encountered. Then it was a grade 5 we consider only in 21 patients, then leading to the permanent discontinuation of darolutamide. Now coming to the rate of most common side effects were lower and similar between the treatment arms. Now the rate of side effects commonly associated with ARPIs were similar across the treatment arm also. That is the same. Now coming to the darolutamide confers a positive impact on HR quality of life. Now coming to the darolutamide extended median time of duration in the impact P total scores of performance scores by 5.1 months versus the placebo. We see that performance total score of Aranode trial, which we have taken, was stratified as hazard ratio of 0.76, and it was around the median in the darolutamide arm was 16.6 months versus 11.5 months in the placebo arm. Now, darolutamide is the first and only ARI to demonstrate a clinically meaningful delay in the pain progression and overall well-being. Now, darolutamide doublet therapy demonstrate a clinically meaningful delay in deterioration of overall well-being, especially on social, functional, and urinary symptoms domain. Now, when we compare this PACT, we call as a PACT score data, this was good in darolutamide, as we can say that brain does not crosses blood-brain barrier. Now, coming to the conclusion, the darolutamide plus ADT significantly improves the PFS of a patient in metastatic hormone-sensitive prostate cancer. Darolutamide showed a benefit across all secondary endpoints, that is delay in castration-resistant prostate cancer, time of progression, and the pain progression was also decreased, and also the PSA was lower for a sustainable time. Now, the darolutamide was associated with the deep PSA response regardless to the baseline PSA. The baseline in cases when we use the PSA of around 50, also the deep PSA response was seen. Now, darolutamide is the first only ARIs to demonstrate a clinically meaningful delay in the pain progression, overall well-being, that includes in the PACT-P, that is social, family well-being, functional well-being, and the urinary symptoms. The darolutamide has a favorable safety profile, and darolutamide plus ADT without docetaxel should become an additional standard of care for hormone-sensitive prostate cancer. Now, which are not strength most impact adoption versus the currently approved doublet?
I think, madam.
This is a question answer session.
Yes, yes.
Okay, so this is like, but this is all for darolutamide and Arnold trial. Thank you.
Thank you very much, ma'am. Thank you very much, Arpita ma'am. Thank you very much, Smita ma'am. It was very nice discussion in both the cases with triplet as well as doublet, and both has got different benefit altogether, as you have rightly said. So if you find high volume, high risk, and the patient has got lesser age, so hard, fast, hard hit. And in case of patients where the safety is very much essential when the patient is in elderly condition, as rightly said by you, ma'am. So in that case, our anonymity is there where LT with our darolutamide Nubeqa can give the best of the best response in terms of both safety, efficacy, at the same time quality of life. And moreover, DDI is where 8 out of 10 patients there are with polypharmacy, if I'm not wrong. So looking at all those, thanks for the wonderful discussion. and looking forward to you, Smita ma'am, for such good sessions in coming future. So with this, I would like to end the session here now. Thank you very much. Thank you. Thanks to all. Join.
Thank you.